I want to welcome our audience back and our panelists that you're going to be hearing. I'm Dr. Albert Rizzo, Chief Medical Officer of the American Lung Association, and the ALA is proud to help co-sponsor this event. Per your agenda, the next 2 hours will continue a discussion that has been taking place over the last several years of this workshop's work related to the non-lung cancer information obtained from a low-dose CT scan and why it's becoming more and more important for these findings to be identified, standardized, and utilized to help clinicians make earlier and more informed interventions regarding the health of their tobacco-exposed patients. CT screening for lung cancer has emerged as a major tool to reduce lung cancer mortality, and screening thoracic images, as we have just heard, are now also routinely revealing the presence of early emphysema, interstitial lung changes, and coronary calcification. The American College of Radiology now has a database of over 4.5 million scans that have these non-cancerous findings likely related to the tobacco-exposed population. The finding of emphysema may be acting as a radiographic biomarker of an individual who is at risk for development of symptomatic, clinically relevant obstructive airways disease, as well as more risk for the development of lung cancer. Findings of interstitial changes may be similar markers to the early progressive fibrotic diseases that we encounter. Today's panel discussions will show the importance of identifying and acting on these findings, even though there may be no specific intervention or modifying agent currently available for emphysema. But there are things that can be done. As a result of previous workshops, we published an editorial that encouraged more focused smoking cessation intervention, as well as stressing the healthy lifestyle interventions, including exercise, weight management, and sleep when emphysema is noted on scans. We are also encouraging new research to refine these and related non-pharmacologic interventions in this context, as well as encouraging tailored pharmacologic research in the setting of a screen-detected pre-symptomatic lung disease, be it emphysema, fibrosis, really for the goal of preempting progression. Now, although we have two separate panels for today's discussion, we want interaction to occur across the panels and certainly with you, our audience. As the brief presentations occur, feel free to put comments or questions in the chat for discussion. The first panel will be moderated by Dr. George Washko, who will deal with large databases of CT scans that are being collected and harmonized, hopefully such that machine learning of this data will lead to meaningful clinical understanding of the process, therefore leading to interventions in lung diseases. The second panel, moderated by Dr. Javier Zulueta, will discuss the shared pathophysiology behind the creation of these CT images that are likely due to the lung's response to inhaled triggers, be it infections, toxins, or pollution, all of which incite the immune system. This leads to a tissue microbiome of inflammation, and this environment can drive progression of a spectrum of interrelated thoracic diseases, emphysema, cancer, and fibrosis. We may be at a point when these radiologic biomarkers and tissue biomarkers could be coupled to stratify risk of developing disease or cancer and indicate that these findings may be utilized to the benefit of patients on a day-to-day basis. During today's discussion, I ask you to keep several questions in the back of your mind. Can we postulate that pulmonary emphysema or pulmonary fibrosis can be repaired? If so, are there candidate drugs that have biological rationale for lung regrowth or repair? And how can improvement in lung repair or regrowth be measured? I'm now going to turn things over to Dr. Washko to introduce our first panel. George?
Perfect. Well, thank you, Al, and thank you, James, and everyone. It's an honor to be here today and to be back for the workshop. We have a great 2-hour session, and so Javier and I have been in discussions about how best to moderate this process. What we want to make sure we do over the next 2 hours. Am I on mute?
You're good, George.
You're good.
Okay.
We can hear you.
Because there was a comment that said I'm on mute. Sorry about that. One of the things we want to do is we want to make sure we give every one of our speakers time to talk, and we also want some cross-pollination amongst the speakers. So we want to have, what we're going to do is we're going to have the first panel. We'll have some brief wrap-up discussion and questions related to that. We'll get into the second panel, and have a similar wrap up. And then we want to spend some time talking amongst all of us. So to really kick us off, I'll start with our first speaker. And it's my pleasure to introduce Dr. Graham Barr. Dr. Barr is a physician scientist based at Columbia University. He's been involved in and has had a leadership role in many of the large ongoing observational studies focused on respiratory health in the US and really around the world. When he's not buried in administrative responsibilities, he likes to focus on research where he has an expertise that spans cardiopulmonary interdependence to machine learning-based characterization of the lungs in multiple modalities, including CT scan, dual energy CT scan, and MRI. And it's really a great pleasure to have him here today. And so, Dr. Barr, over to you.
George, thank you very much for that very kind introduction. First of all, I hope you can hear me. And then secondly, hopefully you can see my slides if things are going exceptionally well.
You're all good.
Yeah, great. Okay, thanks so much. Well, I just have a few slides to hit what I hope are a couple of high points on quantitative lung imaging. And I'm going to focus in the multi-ethnic cohort studies that I've been involved in, but want to make it clear that there is huge work coming out of multiple groups, and this is just a very selective sort of highlight. And we're all working together to try to move this forward. I'm going to speak mostly about the multi-ethnic study of atherosclerosis lung study and also C4R, which I'll explain in a minute. And probably just sort of hit a couple of standard measures and then bring up some newer ones that might be of interest to the group, and then a final word of caution. So we have been interested in, as have others for a long time, in quantitative assessment of the amount of emphysema, which can be termed percent emphysema, or low attenuation areas and thresholds in various different ways and measured with different approaches, and whether that actually matters on a CT scan. So these slides show results on percent emphysema and mortality in a general population sample, and on the left, limited to those with normal lung function, and on the right, in a broader group, including smokers and non-smokers. This is about 6,000 people or 3,000 people with normal lung function in MESA lung, and followed for about 6 years, and about 6,000 people with mostly with normal lung function on the right. Followed for about 8 years. And what this shows is that if you have more emphysematous voxels in the lung, over time, your hazard ratio of a death is increased. This is all-cause mortality up around 2.5-fold increase in death risk in the general population sample, greater in people with a history of smoking. And on the right, if we threshold for an amount of emphysema, CT, which about 10% of the sample, general population sample again here, has, you see an increase in deaths from lung disease. There's also not shown in this paper deaths from lung cancer, from cardiovascular disease, and all-cause mortality. So it would seem, and I should point out that these scans are from actually from Bob Tutrano, who was referenced earlier, that was originally used for coronary calcium scanning. And here we did sort of the opposite of what's being proposed for lung cancer screening here, where these were coronary calcium scans that visualized about 2/3 of the lung that we then read the lungs on. And this is also correlated with cardiac output, as we showed on MR a few years ago. So I think it is worth emphasizing that the lungs remain the sort of unique organ where we look at routinely. We say, hey, there's large chunks missing, but that's not fully a disease, and we shouldn't really worry about it too much. So I think these and other data suggest that actually, if you are missing large chunks of your lung, that matters. We know what to call it in terms of emphysema, and we're starting to learn what we should be doing about it, certainly related to smoking cessation, checking for spirometrically defined COPD, and so forth. And this is an opportunity that will only hopefully grow over time with well-done cohort studies and further therapeutics. I'm going to turn to a couple of other things for consideration that can also be pulled off on lung cancer screening CT scans. Again, these are now moving into a full lung scan. That's a low dose scan. Ben Smith and others in the group have recently published that dysynapsis, which is small lumen areas in the airways compared to big lung volumes, which is an old concept in PFTs going back to the 1970s, is actually highly variable in the general population. So these are scans from MESA where just across quintiles of dysynapsis, you can see on the left, for about the same lung volume, there's a remarkably small airway tree, and then we go over to the right, there's a visually much larger airway tree. And this is, it turns out, is relatively stable over adult life, and it's almost certainly developmental. And it's a major risk factor, as we published in JAMA, for incident COPD, actually greater than smoking in a general population sample, and also not associated with accelerated decline in lung function. So in other words, you can get the COPD by essentially having dysynapsis, or you can have a lot of smoking that's causing the accelerated decline in lung function during adulthood. And this also, Ben has work coming up to be published soon, showing also predicts cardiovascular mortality and lung cancer mortality in MESA, which probably is related to deposition of smoking. Of course, we can do more on these CT images, which are large and dense and packed with data. We've made some attempts over a few years on using unsupervised machine learning to redo, if you like, assessment of CT emphysema subtypes. If you go back to the original literature on subtypes of emphysema, which are biologically very distinct, even in the classic literature, they're based on about 70, 30, and 10 autopsies from the 1950s and 60s. And radiologists can read those with varying degrees of accuracy, and usually don't, and they're sort of ignored in the guidelines. So we went back and we did a training on 2 training sets of about 1,500 participants each in spiromics, which is a COPD study of heavy smokers, and used an unsupervised approach to cluster based on these regions of lung based on texture and position in the lung, which essentially is using, I don't want to call it, the engineers don't like when I say this is like facial recognition, trying to see the same pictures on your iPhone. It's not from a coding point of view, that's not analogous, but from an English major point of view, it is analogous. So what we found was really 6 emphysema subtypes that were highly reproducibly learned and highly reproducibly labeled on repeat scanning, and have varying distributions in a heavy smoking cohort like of COPD, like spiromics in blue here, and but also present in the general population, red in MESA. And to our surprise, after all this work, what we found in very quantitative ways was essentially blue bloaters and pink puffers, respectively. It's almost word for word the Burroughs Lancet 1966 publication. So an amazing coincidence, or really those guys had found something important, and hopefully we can move forward here. I think we all agree that sample size matters when we're using AI and AI-related techniques. So we're also lucky to be working the collaborative cohorts for cohort COVID research, which Lizzie Olsner here leads, mostly focused on harmonization of non-imaging data, but with appreciation to the American Lung Association for funding image-based harmonization of scans from these cohorts listed here. We are in the process of using deep learning-based approaches to imaging-based harmonization for around 20,000 participants in these very phenotyped cohorts. We can now do things like deep learning lung volumes from cardiac CTs and sort of regrowing the missing apex on the cardiac scans. harmonizing the airway measures, which turns out is considerably harder than one would think, and using texture-based methods across these cohorts, with a lot of help from quite a few people on the call. I'll just end by saying we know, we're learning a lot about artificial intelligence, but we really need to think about artificial stupidity, if you like. Things can go wrong with AI, and they can go wrong very badly and very quickly. One of my favorite examples within our group, I'm sure we're not completely alone, and of course we haven't published this, is we've spent a lot of time using deep learning of lung segmentation on MRI scans. So what I'm showing here is a lung MRI, which of course is not as beautiful as a CT scan for the lungs, at least. The heart looks better. And using super resolution and other approaches, we can apply what we know, or the machine knows, for lung segmentation on cardiac scans to MR images. And you can see visually, this looks like it's working pretty well. And indeed, we ran this through hundreds of MRs of the lung, and it worked very reproducibly, very well, and we were very happy. We then had an improvement in our MR imaging sequences and get better information on the lung. And what you can see here is indeed, we can see sort of airways and things like that on this MR image from the same scanner, but a better sequence. And we reran our algorithm thinking everything would be simple. And the red areas were found as being the lung, according to the AI algorithm. So in this example, it's very obvious that this was a complete fail of the algorithm. But unfortunately, often we are trying to understand whether something's working or not working. And these minor adjustments in scanner or changes in scanner or algorithm and so on and so forth can have huge consequences in terms of what the results we're getting are. So, and this, of course, is a larger issue. I don't think here we're talking about extremes of catastrophic danger of AI, and this is from The Guardian yesterday, the Bletchley Summit in the UK on an international collaboration on kind of trying to put guardrails here. But we need to be mindful and do rigorous science to make sure things are really working before they're unleashed broadly. And with that, I'll end. Thank you very much.
Oh, perfect. Well, thank you, Graham. That was fantastic. Bold of you to volunteer that error. We've never had a segmentation issue, so I'm glad to see. I've heard about them, and I suppose now we have hard data, right? I think just a fantastic overview of patterns of injury on imaging, but also this question of intrinsic susceptibility or resilience to injury, right? It's saying that it's more than there are things that we're born and designed around that I think can sort of preordain some of our disease trajectories. And I love that you can pull that out of imaging. I could spend hours sort of asking questions and talking. What we're going to do, though, is get through the speakers, and then we'll open it up to the group for some questions before we pivot over to Dr. Zulueta. So our next speakers are Elizabeth Estes and Dr. Simon Walsh. Elizabeth comes to us and represents the Open Source Imaging Consortium, or OSIC, and Dr. Walsh is a physician scientist based at Imperial College in London. He's an expert in the application of machine learning and deep learning-based algorithms for the detection and characterization of parenchymal lung disease on CT. And really, Simon has led many of the international efforts to standardize automatic image analysis for patients with ILD. And it's a great pleasure to have you both here today, and it's over to you.
Thanks, George. Can you hear me okay?
Yep.
And can you see the slides?
Yep. You're in presenter view. Yeah.
All right, great. That's what I want to be in. Well, welcome everybody, and thank you very much. I'm Elizabeth Estes, as George mentioned, and I'm not going to do much more of the intros, although Dr. Barr, I think I am the artificial stupidity part of this presentation, so bear with me on this, and then I'll hand it over to Simon for the science side. Really quickly, a little bit about OSIC. Our mission is to be passionate in our quest to make radical progress on behalf of people living with fibrosing lung diseases and to deliver actionable solutions. We say from the beginning, if we can't get it to the doctors at the bedside, we've failed. We're a not-for-profit cooperative founded in 2017. What we do is we ask academic institutions to provide us with 500 scans or imaging data and scans. They get access to the entire database. Industry and technology partners fee-based, and patient organizations are free. And I have to say at this moment, thank you to the American Lung Association for being behind this initiative from the beginning, from 2017, and for Deb Brown, the Chief Mission Officer of the American Lung Association, for sitting on the board, and for Al Rizzo for being a brilliant sounding board more times than he probably has wished. We do have the largest and most diverse, curated, and integrated ILD imaging and data set. And anything that OSIC creates, we will give to the world open source. So Simon, let's talk a little about why this was so important and why we needed this.
Thanks, Elizabeth. So currently the standard test for measuring disease progression in fibrotic lung disease is forced vital capacity, or FVC. And we know that antifibrotic therapy slows FVC decline. But the problem with FVC, as you know, is that it's limited by measurement variability and it's prone to missing data. And as the drugs that we produce get better, the treatment effects will get incrementally smaller. So we need something more sensitive and more reliable. And this is where imaging comes in. So CT is central to diagnosis in fibrotic lung disease. It can be used to predict outcome, monitor disease progression, response to treatment, etc. And it's also central to drug trial enrollment eligibility assessments. And as it's performed in all patients with fibrotic lung disease, it's a compelling source of novel biomarkers. However, radiologists are not as good as they think they are insofar as CT evaluation is subjective, which makes the case for objective computer-based CT evaluation. And now with deep learning approaches, we have the opportunity to access imaging biomarkers that are inaccessible visually. So this means less lung biopsies, faster drug trials, more rapid novel treatment discovery, more consistent patient enrollment in trials, and what we're really all aiming for, enhanced precision medicine in the clinic. So keep in mind that 50% of screen failures in drug trials of antifibrotic therapy are due to CT reads, and potentially CT misclassification, which pretty much sets me up for the next slide. Okay. Right. So as I see it, there are three key imaging-based challenges in fibrotic lung disease, and these are all amenable to AI or deep learning-based solutions. The first big issue is that CT is liable to high levels of inter-observer variability, particularly when making diagnosis. And this is true even in the hands of expert radiologists. To address this specific problem, in 2018, just as an example, we developed a deep learning model for providing diagnostic support in the setting of fibrotic lung disease. And this is currently the focus of a global diagnostic utility study called the SOPHIA project.
So as Simon said, this was a major issue for us. So how can OSIC help solve this? So first of all, the prior limitations were there were insufficient number of CTs. They were more homogeneous. And when you're trying to solve a heterogeneous disease, we need to make sure that we have a lot of data and real world data from all over. As was mentioned before, this isn't a first world problem. This is a world problem. And the data needs to address that. And we made a very distinctive decision in the beginning, building OSIC, that we wanted this data to be real world so that the algorithms worked around the world. There were limited collaborations at the time, and generative AI needs lots of data, specifically longitudinal. So our goal was to build this database from every region in the world. We're announcing and launching the new cloud on October 13th. Right now, we have 20,000 committed cases. We have 5,000, almost 5,000 patients in. For those of you in the COPD and emphysema world, that seems minuscule, but in the ILD world, that's a large database. One thing that was interesting to me that Dr. Mulshine mentioned was the standards that are needed with any of these AI algorithms in any disease, and he's so right. The front-end ecosystem needs more standards, both radiology standards, EMR standards, and our job at OSIC is to put out some papers in the next year talking about and pushing forward so that people understand from a real-world position what we've seen in our database and how different they are and what that can do to algorithms. So that's one of our goals. Simon, go to 2.
Yeah, so the second big problem is identifying patients who are going to progress using their baseline information. In other words, when they first come into the clinic and are seen by the doctor, can we sift out the patients who are likely to develop so-called progressive pulmonary fibrosis versus those who are treatment amenable or who are likely to remain stable? And this is critically important because antifibrotic therapy eligibility is based on defining or diagnosing progressive pulmonary fibrosis. So our current paradigm is that we have to wait and observe a period of progression before patients become eligible for treatment, which obviously is less than ideal because they have lung function decline during that period. And it also leads to more lung biopsies, which is a big problem because surgical lung biopsy has a 2% in-house 30-day mortality, which is significant. 1 in 50 patients will die within 30 days following a lung biopsy, lung fibrosis patients, that is.
So our solution to this was, and the approach was, how do we refine the clinical data that we're bringing into the database? So how do we make sure we know what we need to try to figure out progression? Over here on the side, the right side of the scan, these are just a couple of our AI companies that are working in an OSIC and OSIC members who are sharing their information for ILA quantification. We also have, they've done lung shape, they've done all sorts of different quantifications and weighting for this. So our goal is to drive more longitudinal scans because we've realized the importance of those for these algorithms. And then also we're starting to add more forms of data. We have a really interesting opportunity to bring in sound because, as we know, lung diseases sound differently. So that's super exciting. We're bringing in NLP and native language processing onto our cloud platform. And then Project Opus is a project that we're doing where we're consenting patients and giving them daily home Bluetooth spirometry to try to look at geography and air quality, which I know is a big push and interest into the American Lung Association and all of you. Simon, last one.
So the third problem is that in fibrotic lung disease, our current diagnostic paradigm is that we wait for symptoms, we do a CT, we identify fibrosis, and at that stage, the patient has had lung function decline, and there's a sort of an opportunity missed. This has been likened to diagnosing coronary artery disease in a patient after they've had a heart attack. So what we do know from longitudinal lung cancer screening studies and cardiovascular trials that some patients, in fact, 7 to 9% of these patients in these studies have what are called interstitial lung abnormalities, or ILA. And we know that a small percentage, about 10% of these, represent the precursors of progressive pulmonary fibrosis. But the problem here is sifting out the progressive ILA against a sort of a sea of stable or biologically insignificant ILA. And this is essentially an image classification problem that's tailor-made for deep learning methodologies. But to do this work, we're going to need large quantities of CT data.
So what we're doing now is we're bringing in lung cancer screens, which I know all of you care about and have, but we're bringing in the lung cancer screening data into the cloud database to try to do exactly what Simon said, categorize those and create biomarkers from the lung cancer screens to ILAs to ILDs. I know the ILA conversation is a massive one. So we'll have 10,000 lung cancer screens added by the end of this year. And the goal is 100,000 in 2024. And we currently, thanks to some European partners and other partners, have about 40,000 committed. So it would be our goal to get as many lung cancer screens with ILA and ILD follow-ups as we can to try to help earlier diagnosis on this. And then the last one, Simon, to you.
Yeah, so OSIC's solution to this problem is developing a massive database of imaging to drive the machine learning research. But the other thing that we can do to amplify the amount of data that we have is to progress generative AI. In other words, developing synthetic data or synthetic imaging data that we can use in model training. And some of the work that we're doing at Imperial College now has demonstrated that it is feasible to generate synthetic CT data to amplify or fine-tune or improve deep learning model training in this particular setting.
So thank you very much for inviting us. We really appreciate it. And there's our information. George, back to you.
Awesome. No, thank you both so much. I mean, OSIC is, I think it's really exciting. A lot of thoughts I have, questions even about how you assembled the vision to have such a long-term, broad-based investment of energy is something I definitely want to circle back to. And of course, then these ILA and knowing the fraction of smokers who have them, and then the fraction of those that progress means massive database. And I'm also then thinking about what Graham is tackling around image standardization, how you weave all this in. It could be a lifetime investment of energy. So maybe what I'll do now is I'll pivot over just to our last speaker. And I have really the honor of introducing Dr. Lecia Sequist. So Dr. Sequist is a physician scientist based at Massachusetts General Hospital here in Boston. She's a practicing oncologist. In addition to a recent high-profile work using advanced image analytics to identify people at greatest risk for future lung cancer, she designed, built, and leads the Cancer Early Detection and Diagnostic Clinic at MGH. And I think what's really exciting is that Lecia created the infrastructure to leverage quantitative imaging and bring it to the bedside to improve patient care. And so it's awesome to have you here, Dr. Sequist, and over to you. Oh, I think, Lecia, are you on mute? I cannot. No.
How about this? Is that better?
Perfect. Perfect.
Okay. Sorry. I had my microphone turned down. Thank you. So it's really a pleasure to be here. And I have just a few slides. So maybe I'll talk a little bit more, then I'll forward the slides along. So I'm an oncologist, and my area of interest is a little bit different than some of our other speakers. So I don't focus as much on fibrotic lung disease or COPD, but really in treating lung cancer patients and trying to find more lung cancer patients at an early stage instead of the advanced stage where I usually encounter them. So this work for which I've asked to be part of this panel is a collaboration that I did with MIT. And really the problem we were trying to tackle is, I think this audience is well aware that we're not screening the eligible population around the world very, very robustly for lung cancer. But taking a look at it from the opposite end, as a medical oncologist, if you start with, on the left-hand side, all of the patients in the US diagnosed with lung cancer every year, even if we were doing 100% screening among those who are currently eligible under the USPSTF, you see there's still more than half of the patients diagnosed with lung cancer would not have been eligible to be screened. And that's because the epidemiology of lung cancer is changing. We are still seeing smoking-related lung cancer, of course, but more and more of our patients have very light or never smoking histories, very remote decades ago. And as you're familiar with, no doubt, there's been increasing evidence that air pollution, and other population level effects are likely part of the new epidemiology of lung cancer that we're seeing. So even if we were, and of course, then this the second to the third bar gap is the fact that we are not really following the eligibility criteria. But this first gap highlights our need to be able to understand who's going to be at risk for lung cancer. It's not merely so simple as whether you've had a specific threshold smoking history. There's probably a lot more that goes into it. So that was a problem we set out to try to solve in this collaboration with MIT. And we built this algorithm, this image-based machine learning algorithm called Sybil, which was trained on the NLST scans from the pivotal lung screening trial, and basically is trying to look for patterns in the entire 3D volumetric data contained within a CAT scan that are associated with developing lung cancer. And so the model was trained to predict 1 through 6 year future lung cancer risk for each low-dose CT. And there's no image annotation that's needed. So this is not a nodule assessment AI algorithm. No radiologist needs to indicate any sort of structures or regions of interest. There's no clinical data needed. You don't need to input things about smoking history, sex, age. And you get both future risk and near-term risk stratification. So you can see, if you are interested in hearing more about the nuances of the data that we found, this is our publication earlier this year in the Journal of Clinical Oncology. In order to be brief, I'm not going to go over all of the different AUCs for the different subgroups. We had 3 independent validation cohorts. But what I thought I'd show you instead is sort of just a case example of how this could be helpful clinically. So you could imagine if we were doing a larger screening, and we were screening maybe the general population instead of specific smoking cutoff criteria, that you would want to risk stratify patients and figure out who needed to be screened more frequently and who are the people that truly are at very low risk for developing lung cancer in the next 5-6 years and don't need to be screened. So this is an example of how that could work. This is an actual patient from the National Lung Screening Trial. This was their baseline scan, which the radiologist thought looked fairly normal, no worrisome nodules. However, when Sybil looked at this scan, not just this slice, but the entire 3D volume, they placed the scan in the 75th risk percentile. Now this isn't a standard part of the Sybil algorithm, but just for the purposes of this example, we asked the model to color code the regions of the lung that led to that verdict, that 75th or high risk percentile. And the attention of the model was really kind of honed in on this area in the right lung. So this is not a PET scan. It looks kind of like a clinical PET scan, but this is an attention map of the model. And when this patient came back for their next scan, indeed, there was a relatively sizable tumor that had grown in the interval. This was a win for the NLST. I mean, this is a screen-detected stage 1 lung cancer. The patient went on to have surgery. But we know in the real world that most patients do not come back after a negative scan. And so this patient in the real world probably would have been a missed cancer and probably would not have been stage 1 by the time they presented. And this, I think, illustrates how having a risk model to tell you who really needs to be screened and who to focus on might not only help us catch cancers in patients like this, but also open up screening to potentially the general population, because we would be then risk stratifying each patient going forward, just like we do with other types of screening, like colonoscopy. Everyone's supposed to get their baseline colonoscopy at age 45. And then, depending on what is seen, you may come back in 3 years, 5 years, or not for 10 years. So those are all the slides I have, but I look forward to speaking more with everybody in the panel discussion.
Oh, thank you. That was a fantastic presentation. Great slides. I'm looking here in the chat. I don't see anything right now. So maybe I can take my minimal privilege here as the moderator and jump in and ask a few questions as we're waiting for things. And maybe I'll go reverse order and Lecia, ask you first question. There's a huge amount of work, as you know, in looking at nodule discrimination, right? What is the nodule risk score? Can we apply all the latest and greatest blood work, machine learning, AI to all the different data analytics? You're taking a different approach and saying risk of future disease. Now, because you are really at the interface of collecting the data and then sort of communicating those data back to your patients, how does that sell? If you sit down with someone and you say, you're high risk of developing lung cancer in 6 years, what's your sense? Will people be like, that's the last thing I want to know? Or will they say, this is great? How do you integrate all this, right?
Yeah, I don't think one size fits all. And communicating this type of vague predictive information to patients is definitely something that needs further study, but it's not dissimilar from other things we do in preventive health. We check people's blood pressure and tell them they may be at risk for a stroke in the future. We don't know exactly where, we don't know exactly when, but we try to reduce their risk if we can by lowering their blood pressure. So, I think there's other things that are akin to this. It is very different from the model that we followed in lung cancer screening, which is to really focus on visible nodules and follow them and try and learn if they're high or low risk. So I think they're complementary. I don't think this is the one tool that's going to answer everything. I think we will need nodule adjudication tools as well.
Good. Excellent. Thank you. And so I see a question here in the chat. And it said and this again, Lecia, is for you. At the beginning of your presentation, you effectively showed the high proportion of lung cancer is not included in screening eligibility. Can your AI output give insight into high-risk people who are not included in the NLST criteria? Are there gating or limitations around what you can do?
Yeah, it's a great question. So the model was trained on the NLST cohort of scans. So this is an American population, a predominantly white population, and folks with a moderate to heavy history of tobacco exposure. However, one of the 3 validation cohorts that we've studied so far, once the model was built and trained, we locked it and validated it. And one of the 3 validation cohorts was actually in about 20,000 scans from Taiwan. And so these are population level screening is already happening in Taiwan. Many of these patients were never smokers, but it included people who smoked as well. And the model actually performed very well, if not the best. The best AUC numbers were from that 3rd validation cohort. So we are actively trying to do other validation cohorts to increase racial diversity, to increase the diversity of different exposures and genetics and other factors of the patients we've studied. It's early days, but I do think, based on the Taiwan validation cohort that we've already completed and published, that I think it is possible that something like this could work even among those who have not smoked in the past.
Great, thank you. Now I see there's several other questions, Lecia, and follow on for there. What I want to do, though, is pick the brains of the people on the panel as well. So maybe what we can do, these are great questions, we can circle back. I guess before I dive into that, Javier, I see your hand is up.
Yes, but I have a specific question to Dr. Sequist. If you want to leave that for the later, I'm happy with that.
Yeah, maybe we can circle back to that. Sorry, I don't want to cut anyone off, though. And I wish we had hours to talk. So maybe now, getting into the middle presentation, Elizabeth and Simon, maybe you can sort of provide a little more insight broadly into OSIC. How does OSIC have the vision for doing a large, but I think a long-term investment? The ILA and these interstitial diseases are a slow-growing process, and so you have to have a team with the patience of waiting years and years. It's very antithetical to, I think, the current pharma mantra, right?
Simon, do you want to take that, or do you want me to?
I mean, I can sort of give a preliminary comment rather than an answer, because George, when you ask that question, it opens a massive can of worms and a lot more questions. It is a formidable ambition, because, as you say, it's a game of numbers. You have 7 to 9% of lung cancer screening trials of ILA. Only about 10% of those have progressive disease. You need a large data set that's well labeled in order to drive if you're doing deep learning based research, to drive the deep learning research. And then you also need to, as you say, then have the follow-up imaging to label those initial ILAs being progressive or not, which takes time. But I think that as a sort of a broad advertisement style comment, OSIC is highly networked now, because we have a lot of members and a lot of contributors, and I think we are well positioned to get access to the lung cancer screening data that we need in order to do this. But how successful we will be, I'm confident that we're going to be able to weigh in on this particular problem. But the proof is in the pudding, so to speak. We're going to have to see how that works out. It's a sizable challenge.
And just to add on to that, George, I think, I don't want to take away from our focus, right, which is to make radical progress on behalf of these patients living with fibrosing lung diseases. So when we talk about lung cancer screens, we care about them in the context of ILA and ILD. I'm not trying to go where everybody else has gone. We don't want to be a mile wide and an inch deep. We want to focus in the ILA and ILD space. But one of our mandates from the beginning was earlier diagnosis. And the only way to do that is to understand if we can see an ILA. And again, let's not debate what an ILA is, because I've heard 8 million different discussions of that. That's a whole nother workshop in and of itself. George, you can host that one. But an ILA, which ones will turn to an ILD? And from those ILDs, which ones will become progressive? So this is very much in the mission of OSIC. I think us staying where we are. We have the largest database, and we've made great progress on quantification, understanding progression, and even mortality. Now it's time to back up to the I don't want to call it low-hanging fruit because that minimizes the importance of it, but to back up for this earlier diagnosis part of it. And it has to be a conversation with lung cancer screens because of the connection with smoking. Because we know, and you know, Dr. Mulshine talked about it in the beginning, visualizing the full impact of 20 years of smoking, that impacts ILA and ILD. So we have to go there.
No, this is great. And thank you both. Again, you know, I could spend hours asking questions and picking your brains about these things. And one of the things that I'm thinking about, and now Graham, I'm looking at you and sort of learning or pondering over the OSIC experience of heterogeneous clinically acquired data standardization. And so what they're endeavoring to do with maybe more external support, you are focused on through an academic enterprise, right? Sort of C4R. And so maybe, and I'm not sure, because we didn't have a lot of time, but to give you enough sort of airtime to truly expand on what that is, because it's quite a large endeavor. And so maybe you can even just comment briefly on, like, is it actually possible to standardize all of these data? You know, we see in the clinical scans are all over the place, right? And so, you know, is your experience that we can get great data, and you know, how are you even building around this? Can you tell a little more about C4R?
Yeah, sure. Thank you very much. So, I mean, I think this has been a great workshop, and I think that there is a lot we can do. And I think a lot is some things are relatively simple in the quantitative space. And, you know, for example, the example I gave with MRI, I mean, segmentation of the lung on CT scan, I think we agree is pretty good at this point. And it was one of the reasons I wanted to show the MR example where it didn't work. But, you know, that as a task, you know, is pretty scanner independent, I think we would say, is pretty protocol independent. We have all these problems with inspiration and so forth. But, you know, I think we can do that, clinical scans and otherwise. Then we start getting into thresholds, density, emphysema, texture, and so on and so forth. And I think as everyone on this, certainly on this panel, is well aware, it gets very challenging. For example, you know, we have to keep in mind that most of the results we've been looking at, or many of the results we've been looking at this morning, are from scanners that were of an era when my phone was I don't know if it'll see this, right? And now we are using different phones, and the scanners have changed. So, you know, and at some level it will all line up, but and for segmentation of volumes it does, but for other things it doesn't, as you well know. So in C4R, we have I think the advantage of a lot of the scans were acquired in major across in highly protocolized, highly standardized protocols and scanners, relatively limited numbers of sites. Many in the cardiac era, the cardiac scans, many following the original MESA protocol, sort of in a sort of period where there wasn't a lot of scanner change. And then as you're doing a lot, and all of us are doing, trying to standardize acquisition as much as possible. The obvious piece to this would be then standardize our clinical medical center scans following the research scans. And I don't know, locally we're still working on that, although I think some sites like Michigan have had more success. So I think there's huge opportunity to expand, but we just need to be realistic about what's working well and know what's working well and what's not. In terms of C4R, I do think it's going to be, you know, we're getting there. It's going to be a great opportunity. We have about 20,000 subjects with scans. It's diverse subjects. The scans are older, as I mentioned, but they're pretty standardized, so the task is a bit easier than, for example, you know, looking across multiple clinical scans right now. And hopefully that sort of will help make a bedrock for learning. And then we can work on translating more directly to contemporary clinical scanners, which I know remains a challenge.
Yeah, great. So you are both our cheerleader and managing our expectations around all this process. So thank you. And it's not lost on me that both C4R and OSIC have about the same number of scans, and maybe there's some potential future collaborations around there too, because I think there's a wealth of data and all that, and I'll sort of leave that for offline discussions. But maybe Javier, now I'll come back over to you. I see your hand is still up.
Yes, thank you. Well, fantastic presentations, and I think this is a great panel, and it leads very well into the next one. Dr. Sequist, I wanted to ask you, and I think somebody has also made reference to this, in that last case that you showed, have you been able to identify what factors or features of the CT scan the civil identifies as providing high risk? That patient seems to have emphysema, for instance, and we know that that is associated with risk. However, that wouldn't explain why it actually places the hot map right over where the cancer starts. But can you expand a little bit on that?
Yeah, I mean, the short answer is no. And the way that these models work, it's not necessarily possible to understand the logic. It's pattern recognition, but what types of patterns are being recognized after seeing thousands of scans is not something we've queried, or I think we can query. Although I will say I'm not the computer scientist in the group. I'm the clinician, and the computer science is being done at MIT. But no, we haven't looked into what it's seeing.
Well, maybe, Javier, what we'll do now is we're getting close to the halfway point, the midpoint of the panel. We can pivot over to your half, so we can get through those talks, questions, and then if people are still available, we can then sort of bring it back together at the end.
Very good. So yeah, I'm excited to introduce this next panel, and we have three, I think, fascinating approaches to the several questions that are being raised here. Our first speaker is going to be Dr. William Dahut, who is the Chief Scientific Officer of the American Cancer Society, and how opportune to have him here today when we just learned about the new ACS guidelines published yesterday for lung cancer screening. Then afterwards, we're going to hear from Professor Larry Schlesinger, from the President and CEO of the Texas Biomedical Research Institute, and from Professor Steve Dubinett, who's the Dean of the David Geffen School of Medicine at UCLA. Let's start with Dr. Dahut, please, and the mic is yours.
Well, thanks so much. And I'm slideless today, so hopefully that doesn't bother anybody. But so this has really been fascinating, and I was actually very interested to hear Dr. Sequist's presentation. I was up at MGH this summer and heard a lot about the early detection clinic, and I really do want to start by emphasizing some of the great points that she brought out. So I think overall, I totally agree with her that, screening should be, our aspirational goals should actually be personalized, precision-based, and sort of adaptable over time. So once one knows their individual risk based on a large variety of criteria, regardless of the cancer, then screening should be based on that. And although she did talk a little about the colonoscopy space, and we obviously know there's screening is differently done for folks who have some inherited germline mutations, in lung cancer, we're not quite there yet. Now, we're actually very excited, about the release of our guidelines, which came out, I think it was released yesterday formally. And I think the really important information is the change in guidelines will increase the number of folks eligible in this country by 37%, by another 5 million or so. And with that, we're making a major educational effort to really increase awareness why this is important. The primary change in our guidelines is really removal of the time since quit criteria, which I think was confusing for folks, for primary care doctors, and it was really based on information we had while after folks stopped smoking, we saw sort of an initial narrowing of the lung cancer gap at the exact age when lung cancer is at its greatest in their 60s, when people were actually stopping the screening. We saw actually a much widening of the disparity between former smokers and never smokers, and where the gap actually was around 8 or 9% per year, sort of a very significant gap. And so I think that's laid into potentially the incredibly sort of abysmal lung cancer screening rates we have in this country. I've had conversations recently with sort of the head of research at Merck, who's a cardiologist. You just can't believe in places like California and Utah, the screening rates, are under 3%. So, hopefully this will make this easier for folks, not sort of in folks' mindsets, that if they had stopped smoking at some point, that they don't need to worry about lung cancer. And I think for the importance of this panel and the people on this call, there will now be 19 million people on our guidelines, eligible on a yearly basis, for lung cancer screening. And so we can sort of imagine, first of all, how this may actually impact sort of the day-to-day clinical work and clinical effort that's needed, but also sort of the ability to sort of think in a way that's maybe more logical how we follow patients up. Who should be primarily responsible for following patients for lung cancer screening, because oftentimes the screening exams will be done by primary care doctors, not by oncologists. Abnormalities will be noted by radiologists, but depending where they are, that may not be someone who can intervene. Referrals are often to pulmonologists, but biopsies are then often done by either by radiologists or particularly by CT surgeons. We're also in a space where lung cancer is clearly the poster child for precision-based medicine. Lung cancer is, as everyone knows, really multiple cancers that are responding very well to targeted-based therapy. Obviously the KRAS inhibitors are the latest to come along, and sensitivity to immune-based therapies. And there's certainly a feasibility in the future that small early lung cancer nodule, cancers could be treated at least initially without surgery or radiation. You could certainly imagine a targeted mRNA vaccine or immuno-oncology or a targeted therapy where it could be treated and then people could be followed and then intervened, locally with surgery or radiation if needed. And I think the other thing I wanted to talk about, is sort of the importance to the American Cancer Society, and I think the cancer field in general, in what broadly is called, the pre-cancer space. So multiple meetings now with the NCI and other areas sort of defining what we mean by pre-cancer. I think it's histologic diagnosis or imaging diagnosis. It's not going to be sort of a circulating tumor cell. There will be, assuming there's an NCI budget and a government budget, there will be funds, I think, in that space. As far as cancer prevention, there's really a general belief that there are going to be ways to intervene in lesions that don't meet the cancer diagnosis, don't have invasive in the basement membrane, but certainly have mutations in other aspects that would put patients at significant risk for cancer. So I think this is an incredibly important meeting, because as we think about areas that we may not have called pre-cancer, that we should be calling cancer, should be included in the space, and that really therapies designed to prevent progression are going to be incredibly important. And finally, the last thing a number from our data is that 42% of cancers are preventable by, half of that's still tobacco, but a lot of it also is going to be due to infectious diseases, metabolism, obesity, alcohol, and other aspects. And sort of the interaction between cardiovascular disease, infectious disease, and cancer is much stronger than I think was really thought of by most oncologists. I'm a medical oncologist, for times past. So as we think of strategies that improve cardiovascular health, pulmonary health, otherwise, it's likely to have a significant impact on cancer mortality. And that's why, I'm really grateful that we have folks here from across the clinical spectrum. So I'll stop there and excited to hear questions as we move on to the rest of the discussion.
Thank you, Bill. This is, I think, 99% of the people on this workshop are probably celebrating the new guidelines. particularly that the elimination of that third criterion of time from quitting. However, as you say, that basically means that many people are going to receive many more low-dose UTs throughout their lifetime. So this idea of personalizing the risk is becoming more and more important, and also, you know, we will have to see if these new criteria actually capture all those cancers that were not captured by the previous criteria. So I think there are a lot of work to be done in this field, and this is wonderful. Maybe we can move on to our next speaker, Professor Larry Schlesinger from Texas Biomed, who I think is going to address a nice approach of correlating inflammatory and immunologic pathways with our understanding of lung cancer.
Thank you very much. Can you all hear me?
Very well.
Okay, thank you. Well, it's really an honor to be on the panel, and it's an audience I don't usually speak to, so I'm a tremendous learner during this session. I'm learning a lot, and Al said to keep it short, so I think Bill Dahut and I follow the same theme of no slides. I'm just going to talk to you. I think I'm quite far afield in some respects from everything I've just heard. And I'm going to be putting out some ideas and concepts which may or may not resonate, but I think might be something important to consider going forward for the field. I'm a cellular immunologist. For people that don't know what I do, I focus on the lungs, and I'm interested in lung immunity, lung immune responses, both at baseline and in response to airborne infections, and have used a number of models over the years. As a physician scientist, you know, the human studies I do are predominantly from bronchoalveolar lavage, but then we correlate in animal models. And at Texas Biomed, we're one of 7 national primate centers. And so we do work to do comparative biology across humans, primates, and rodent species. And most of my work people know me for is in the area of airborne infection, particularly tuberculosis. Well, let me just raise a couple of ideas that come from the inflammation field into the field of lung cancer. And I've done a little bit of work in lung cancer. By the way, I'm calling you from Girona, Spain, and I'm having the challenge of participating in 2 programs simultaneously. So I've not done that before, but it's kind of interesting. So the first thing I'll say is that over the years, we've been very interested in baseline lung immune responses, and it's been known for a long time, and many years ago out of the pulmonary field mostly, that the inflammatory response is tempered in the lungs. There's a regulated immune response. It's different than other organs. It's largely evolutionarily based on the fact that the lungs are exposed to the environment, and an over-inflammatory response would shorten lifespan or health span by creating fibrosis. So this highly regulated immune response is very interesting because it actually leads to a unique immunologic response to airborne infection, as well as the fact that lungs, as you all know, is a major site of lung metastases. And there's been literature on why the lungs may allow for advancement of tumor microenvironments based on that regulated immune response. What's interesting is that work we're doing more recently is in health span, in lifespan research. And what we've been discovering is that as we know that major changes occur, and I think this was mentioned earlier by your awardee, occur earlier in life in the 30s and the 40s. But we've learned that over age 65, if you take an otherwise healthy individual and you've lavaged their lung and it occurs the same degree, although different age equivalency in primates and mice, there's a complete change in the baseline inflammatory state of lungs with age. Over age 65, there is a baseline inflammatory response. Immune cells like alveolar macrophages are completely different after age 65, even in a healthy host. And it's important to consider that when one is considering lung cancer or other inflammatory processes, to know that the immune response is completely different as we age. The second thing is this issue of the link between infection and cancer, which is becoming more and more solid over time in all the literature that we're reading each month. We know that both infection can trigger cancer, but it also can be a major consequence of therapy for cancer. But what's interesting to me is that when we get into immunotherapy, and this was just mentioned, I want to thank Bill Dahut because at least he brought it into the universe of what I'm speaking about, that when we look at the signaling pathways in host cells in response to infectious agents as a trigger, as well as cancer, many of them intersect. And the question would be, can we get a better molecular basis for immune responses by looking at the coordinated response of infection and cancer? And I think that's an area that deserves attention in the future. The third thing that I wanted to bring up is that what we found is that in diabetics and in individuals who have acute alcohol ingestion, this baseline inflammatory response is also quite apparent in the lung. So when one thinks about comorbidities, I'm not sure, I've heard a little bit about that. Certainly smoking changes the lung inflammatory state, and we all know that. But this signature of inflammation seen across diabetes, acute alcoholism, HIV, has a lot of similarity to the lifespan studies I mentioned a while ago. And I think in the context of thinking about either development of cancer, cancer metastases, or progression of cancer, looking at the baseline immunologic state becomes important. So the relationship to cancer, then, from my perspective, is we certainly know about CTs and PET-CT scans, but the question is, can we ultimately get at immune-mediated tumor clearance mechanisms? Can we correlate, and a little bit, I've heard a little bit about this, but are there immune response elements that we can begin to grapple with to dictate either a protective response or a response in the tumor microenvironment that predicts failure? And a little bit of work that I'm aware of in the lung cancer field has identified a few markers. For example, PD-1, there's some studies looking at correlation between CT findings and PD-1. Nature of immune cells, that is ratios of macrophages to lymphocytes and lymphoid tissues in the lung, and even cell death pathways. There's a little bit of work in that area, but it's early and it's rudimentary. What we've been doing at Texas Biomed and work in my lab and my colleagues' lab in the area of airborne tuberculosis is we're able to look at the PET-CT scans, which are hot and show varying size responses, and then be able to take the lungs out and do dissection of granulomas, the granulomatous response, and do deep sequencing of the granulomas, spatial transcriptomics, metabolomics. And subtle changes by PET-CT can be matched with major changes in the nature of those granulomas. And that some of those granulomas actually are quite protective. They have a Th17 response. They have cytotoxic CD8 T cells in there. We can look at necrosis versus apoptosis as cell death pathways versus another granuloma that appears quite similar and is a completely skewed response to Th2 and predicts progression of those granulomatous responses. In a way, the granuloma is a tumor microenvironment. The macrophages are muted in their immune response. There's other markers of immunoregulation within the tumor microenvironment from a spatial standpoint that in some ways resembles granuloma. So the question becomes animal models of human disease, and is there some way we can move the field forward to begin to look at immune-mediated cancer responses that might be important in helping us with this desire for predictability of cancer progression? And I'll end my comment by saying that another challenge in the infectious disease field in this issue about immune responses has been the fact that when one looks in the periphery in the bloodstream, it's been very difficult to look at direct correlations to the lung inflammatory state. So it's hard to correlate periphery to the lung. So we need to do better there. And I'm excited about work we just published recently, where after years of studying lung alveolar environmental factors that regulate macrophage responses, we created this 4-component cocktail where we now can take PBMCs or monocytes from the periphery and incubate them in this cocktail that we've optimized. It took us about 3 years to do this. And in every way that we've studied, these cells are only 6% different in their transcriptomic profile. They have lung inclusions that appear very consistent with surfactant inclusions because we actually include surfactant. And we look at a variety of metabolic factors that really closely mirror the response to freshly obtained lung alveolar macrophages. And that transcriptome of those fresh obtained cells changes markedly after about 6 to 12 hours in vitro. And this model allows us to begin to get a handle on lung responses from the periphery. It's now being used around the world. We're working with a number of different people, and we're interested in clinical cohorts to see whether this model might more faithfully reproduce lung responses than the periphery. So I leave my bottom line message is, how can we marriage a rapidly growing field of lung inflammation and immunity with imaging modalities in the context of lung cancer? Thank you, Javier.
Thank you. This actually leads us perfectly into our last talk. The idea of inflammatory patterns that might be quantifiable or visible on imaging, and I think Professor Dubinett is going to talk to us about how to combine that with biological biomarkers and come up with a better prediction of risk. And looking forward to hearing his comments.
Thank you. And what I'll talk about briefly here very much aligns with what you've heard from my colleagues on the panel. I wanted to begin by saying what I'll describe to you was made possible by funding from the Early Detection Research Network, the NCI Human Tumor Atlas Network, and the VA Lung Precision Oncology Program, but in particular the Stand Up to Cancer team in lung cancer interception that is funded by the American Lung Association and Longevity, and much credit to the American Lung Association for allowing us to continue this work, which is so important. So one of the things that we study is pulmonary premalignancy. And the work that we've done with the help of these funding mechanisms over the past several years leads us to understand that the immune system is paramount in the resolution of premalignancy, but the decrement in cell-mediated immunity is apparent as disease progresses from normal to premalignancy to the associated invasive tumor. So we know that epithelial cells in the field of injury can give rise to distinct premalignant lesions bearing unique genetic aberrations. And over time, a subset of these lesions may escape immune surveillance and progress to invasive disease, whereas others may regress without therapeutic intervention. So it's finally now recognized as a hallmark of cancer. Immune escape has been established as a critical determinant of tumor progression. And the majority of earlier studies focused on the epithelial component of premalignant lesions. And more recently, there is a wealth of data that encompasses inflammation, immunity, and the microenvironment as determinants of progression. So as I said, the centrality of the immune response, including effective recognition of premalignant neoantigens, is now the focus of a potential key determinant of premalignant lesion fate. And with the advent, of course, of lung cancer screening, we have more patients presenting with imaging studies consistent with focal or multifocal pulmonary premalignancy with unknown malignant potential. The premalignancy mutational neoantigen and gene expression landscapes that predict progression have not been fully elucidated, but work is on the way. And the concepts of immune surveillance and immune editing suggests that the host immune response is capable of both recognizing and preventing the outgrowth of invasive disease at the earliest points of cancer development. So I think the question is out there: is immune surveillance and immune editing operative in pulmonary premalignancy? I would say yes. We recognize, we can see immune recognition at the earliest stages, but also immune suppressive networks that may dominate in pulmonary premalignancy. And these events give rise to the suggestion that the scrutiny of the immune contexture in developing premalignancy could enable cancer interception. That is really a strategy that seeks to block the progression of premalignancy to invasive cancer. And I'll mention to you briefly some of our most recent work. One study published last month in Cancer Research in which we're studying the immunopathogenesis of early lung tumorigenesis as it relates to adenocarcinoma. What we did here was to take pre-malignancy from resection specimens and study normal epithelium, pre-malignant lesions, and the invasive disease. This would then led us to be able to look at a variety of subsolid and solid lesions with reference to the normal epithelium. We found that by multiplex immunofluorescence, flow cytometry, and single cell transcriptomics, that there was a significant decrease in gene expression associated with cytolytic activities of tumor-infiltrating natural killer cells and natural killer T cells, and an increase in T regulatory cells that are CD4 and suppress immune responses in subsolid nodules. And we've done this now in two sets of patients, and find that in using these studies, we concluded that a gene expression analysis affords us the ability to look at the details of these relationships. So work is going on now, and a number of studies have been published from our lab and with our collaborators at Boston University and University College London with Sam Janes, Avi Spira, that over time, we're able to see squamous lesions over time. And we see these same events that we're seeing in lung adenocarcinoma at a single point in time. And with robotic bronchoscopy, we'll now be studying longitudinal events that will be important. I think relevant to what my colleague Lecia Sequist discussed regarding Sybil leads us to another point in this. And so we are beginning a collaboration with Lecia and our colleagues at MIT, Regina Barzilay, in running Sybil in the entire Veterans Affairs medical centers throughout the country. And through the VA Lung Precision Oncology Program, which is a unique funding mechanism that was started by the VA 3 years ago, we've been able to ramp up screening in the VA population. And it's to the point now that we anticipate having over 500,000 scans done in the VA population in the coming year. We'll be running Sybil, if we're successful in this, in the background for all of those scans. But to answer the question is about what is the biology associated with that risk over time. We'll also be doing biological studies with some of the same patients to look if we can determine molecular events in the blood, in the nasal epithelium. So I think that this will allow us not only to perhaps increase the performance characteristic of the imaging study, but begin to understand the basis of risk. And the idea and the goal will be to treat risk. And I use that terminology rather than what Jim Mulshine and I have been talking about for the past couple of decades when we called it prevention, because I think we're at an opportunity now to determine risk at a much more sophisticated level, and including those that fall outside the usual groups that we've been identified for screening. Thank you.
Thank you. Fascinating 3 talks that I think link to each other very well. And actually, we can probably, I have a couple of questions on the chat that I'll ask, but then we can open it up maybe to put both panels together, George, because I think there are many, and there's a lot of crosstalk between them. First, Dr. Rizzo is asking, applauding the new ACS guidelines, so he's one of the 99%. And what he's asking is, can you comment, Dr. Dahut, on the strategy to get CMS and other third-party payers to cover individuals who now fall outside the USPSTF criteria and for no cost sharing for the screening CT scan?
Yeah, no, that's a great question. You know, it's sort of one of these vagaries of CMS is that prevention is not covered, as I think folks know. And in order to get preventive screening done, it has to be either through the task force or actually a separate bill through Congress. So there's two different ways to do it. And I think copay really matters. You know, we actually have a bill we're supporting for eliminating copay for PSA testing, and we're talking about $10. So we'll talk to our advocacy folks, you know, ACS Cancer Action Network, about, you know, what we can do. You know, I don't know the timeline for the task force to update things, but I think it's a real important aspect. The other thing is, you know, we're changing our guidelines so there'll be much more living documents as opposed to, you know, updating them, you know, every decade or so, which is how we did here. And I think it was alluded to earlier on. I think there are populations, whether it's the African-American population, whether it's women, that we're seeing lung cancer occurring at greater numbers than we would anticipate based on tobacco years use. And whether that criteria, you know, Jamal Scheid and others know, that was put in initially, you know, it was 30-pack years initially because there was such a concern that screening would be done in populations that, you know, would be of little benefit. So, you know, what the right number is, how much smoking, which populations, I mean, to simplify this as much we can, whether it's all population, as was mentioned earlier, it's unknown, but I think you're right. If people can't have it done, and I think what's encouraging through the VA system, for example, that where the cost is not the aspect, it's really important. So we'll work on our end and obviously work with all the organizations here to see what we can do to encourage coverage.
Thank you. Larry, if I may ask you, or make a comment more than a comment/question regarding the inflammation. I think it's fascinating the fact that you're talking about how different patterns of inflammation might be related or be microenvironments for cancer. You mentioned granulomas. We know that, for instance, on smokers, not all smokers, but many, we do see patterns of inflammation on CT scans, like the respiratory bronchiolitis associated ILD, and there's knowledge that might be associated with squamous on carcinoma. So can you talk a little bit about these patterns of inflammation and how we can maybe Civil could identify those and do its magic? You're muted, Larry.
First of all, I was excited to hear Stephen's studies, and I think they're absolutely critical in thinking about enlarging the way we think about risk. And I want to answer that in part by an interesting finding. We studied household contacts of tuberculosis patients with diabetes. So they didn't have TB, they had diabetes. We were looking at the influence of diabetes in the household contacts versus healthy control. And what we found were subtle differences due to diabetes, but massive differences in RNA sequencing due to smoking. And that ended up, you know, really confounding our results. But I don't think there's any question about the smoking environment changing things. So, you know, I think a lot of this has to do with the fact that there's a signal within that tumor microenvironment or granuloma microenvironment, that the strength of that signal can dictate whether there is actually a productive response within that microenvironment, or whether, in fact, the antigen is such that the immune system is suppressed to an immunoregulatory profile, more of a fibrosis-leading reaction rather than to a acute, let's say, inflammatory response within the lung. You know, I love the fact that we can get to tissue in the human. I mean, this is what we need to do. But those changes that we see in those inflammatory states in the lung are not reproduced in the periphery. I mean, we can't see them. And so, you know, this is a pretty, you know, isolated or unique lung immune environment for which we really need to get a handle on. So I would say there are other markers we've identified, for example, IDO1 and endolamine deaminase is a big one in terms of immune suppression and progression of those granulomas versus protective response. And what's important there is in individuals, and I think you all know about HIV-associated emphysema, but HIV promotes that immunosuppressive environment along with TB, for example. So comorbidities have a major influence in the granuloma environment. I suspect they're going to have a difference in the tumor microenvironment. So, there's not one answer here. I think this is still early days to look at this phenotyping, genotyping. But I think the technology is there, and with spatial transcriptomics, there's a lot more opportunity to look at actually the location of cells within that tumor microenvironment, how they may be influencing response. I'm dancing a little bit to answer you, but I mean, this is the current state of the field.
Very good. Steve, Jim is asking you a question in the chat. He refers to a classic editorial from Tom Petty talking about the similarities between COPD and lung cancer in terms of pathogenesis, and them being maybe different phases of the same process. And the question is that something that we can now study from the perspective of immune response?
I think that's absolutely the case. And I think the answer to this in some sense overlaps with the question you asked Larry, and that is, what are the immune signatures that we might be concerned about? And the environment of the COPD lung, and in somewhat different ways, but also in pulmonary fibrosis, include inflammatory mediators that encourage both transformation and metastatic disease. And the sobering facts that we're finding are these: that the same mediators that induce that transformation, the same molecular pathways, are the ones that also induce metastases.
Yeah.
And so our vision of what we're calling stage 1 disease may underestimate this possibility. So that's why I think we need to move to treating risk. And I'll give you one example of this. Inflammatory mediators upregulate the transcriptional repressors of E-cadherin, which we associate with EMT and metastatic disease. But in fact, EMT is responsible for transformation. So IL-1 beta, PG2 can induce transcriptional repressors such as SNAIL and ZEB1, leading to both transformation and metastatic disease at the same time. And I think this is maybe why we find such a high degree of recurrence following surgery. And we sit in tumor board and say, okay, these were events that occurred below the detection level of our imaging studies. But that's a description of it. It's not a description of the mechanism of what happened. And I think that one of the other factors that we found that's also sobering is that we've discovered epithelial cells that have biophysical properties that are distinct amongst populations we thought were homogeneous. And that is that there's a small population of epithelial cells, when exposed to inflammation, will upregulate their ability for deformability and motility at a level 100-fold higher than their partners. Those epithelial cells have the capacity to move faster than lung cancer cells. And when I discuss this with reviewers that say this can't be possible, I remind them that epithelial movement has been with us a long time, much longer than cancer, right? Wound closure abilities while we're here, and obviously embryonic development as well. So I think we're just beginning to appreciate this heterogeneity with biophysical properties, but it signals to us that we really need to be much more aware of the danger of any lung cancer at all. And I'll say one other thing too about non-smokers. Consistent with what Dr. Sequist described for the Taiwan population, it occurs to me that because of the large elephant in the room, which is smoking. We've obscured our vision of the other risks. And the thing that fits with that for me is in our collaboration with the EDRN and Stand Up to Cancer ALA, Avi Spear's group, together with us, we're studying gene expression, nasal gene expression. And because we have so many non-smokers in our UCLA population of lung cancer patients, we collected a lot of non-smoking nasal epithelium. And at first the BU group said, well, don't send us those nasal epitheliums because it won't work. We rely on smoking. As it turns out, there's a distinct signal in non-smokers in the nasal epithelium. So I think that we need to begin to actually spread our focus, look beyond the elephant and see what else is there. And I'm really hopeful that our collaboration will be able to do that with Lecia and Regina for civil.
Well, thank you. George, I think we probably should open it up to the entire panel. I'm sure the panelists have comments to make, and probably you do too, and for live questions from the audience.
While we're getting set up, I do want to make a plug here for, maybe we should rename it. We've started our first annual cancer prevention conference, or CRUK, focused on the biology, which I guess should be called Cancer Risk, next June in Boston, and we'll go back and forth across the Atlantic every year. So this is exactly the kind of stuff we want to be talking about. We'll be getting information on that soon, but in June in Boston will be the first one on focus on the biology of, I guess, should we call it the cancer risk? But thanks again. So I'll just put that out for people on the call.
If I might, just to be provocative here, and again, somewhat taking off on what Steve had just mentioned, let me just tell you a reductionistic study, but it holds promise for immune predictability. A bottleneck in science is the tremendous heterogeneity of humans. Something we have to realize, or get a handle on, is that heterogeneity. So we did a study where we had 28 healthy adult donors, and we lavaged them, took their alveolar macrophages, and we infected these 28 donors with the identical amount of tuberculosis in the cells. So it's an in vitro study. But before we infected them, we did baseline deep biology, right? All the omics. So we had the omic profile at baseline, which was very heterogeneous among the donors. We infect them and we see a 10-fold difference in growth. Identical number of bacteria, 10-fold difference in growth, 28 donors. We then along the way did all the omics to try to stratify these humans, human cells rather. But we began to identify nodes that correlated with protection versus growth in this in vitro model that could be backtracked to baseline immunology, meaning it holds promise for the idea that we can begin to see a handle on baseline, what I call homeostatic immunology, as a correlate of predicting response. And, this excites me. This tells me that we, have the potential to really dig into predicting immune response in this setting, lung cancer, of course. But I think that's really a goal to focus on.
So I have, maybe I could, this has been a great panel, and thank you everyone. Maybe I start with an observation, and then it comes with a question. But for example, Dr. Schlesinger mentioned that subtle changes in PET are related to subtle differences in the biology of granulomas. What Dr. Sequist mentioned was that there's this field of injury in which you could predict the future development of cancer, right? Visually, we couldn't see stuff that then became stuff later on. I think we don't have the resolution. I think one of the things that's been limiting us with imaging is that we think, well, we're only good in CT down to a millimeter, sub-millimeter. But in fact, I think we're quite good at imputing underlying regional biology, right? The mosaicism of the lung. You can, to a degree, predict mutational load in a tumor based upon the field of injury. you can predict the immunologic profile of that same tumor based on the underlying field of injury. And so there's all these sort of far out cool things we can do because we have these new post-processing tools. And maybe, Lecia, I'm sort of looking to you first. You know, what is then the wish list? What's the next thing? What sort of biology do we impute? What powers patient care or your decision making around all of this? Because we can go anywhere with this stuff.
Yeah, I think we have to be proactive about starting clinical trials to convince frontline clinicians that this type of knowledge is important for them. And listening to everybody talk, it kind of reminds me of all of the information that might be in the microbiome that for a long time, I think the majority of doctors kind of turned away from and thought of this as some sort of holistic medicine, side thing that didn't have to do with them, if talking about manipulating the microbiome. And, over the years, we've seen, especially in cancer treatment and immune therapy treatment for lung cancer, that this might be really important, and certainly many other diseases as well. And I think these other pieces of information that we're getting on imaging, we're not paying attention. It's not the big pneumonia that was, or the broken bone, or the reason that we got the scan, but it's other information that we collected around that. Probably has a lot more information about risk and future disease states of all sorts. But our medical system just isn't used to thinking about those or incorporating them into our clinical decision making. I think it's going to take some carefully constructed trials to show people the benefit of what can happen when you have this information and you pay attention to it. So we really need to lean on implementation science more, is what I'm saying.
I think it may be an opportunity to think also about, often bandied about the term real world evidence, but I mean, if you can have 400,000 scans from the VA and start getting, information on their medical records over time, I'm like you, done lots of clinical trials, and just knowing the tortuous pathway to get to where you want to get to. But if we can show that in patients that have medical records and information now, whether it's linked to Medicare or linked to other aspects, not to replace clinical trials, but to amplify what is seen, might be a way to start to move along the field faster, because otherwise it just gets so damn expensive, as you know. So.
Well, and I also, if I may, I also think that part of this is making sure that we're using the imaging tools that we have now or are building to make these clinical trials more successful. We just had a phase 3 trial in ILD. That should never happen. We know how to choose these patients. We should know how to pick the ones that we know or think could, will do well. And I get a lot, people will say to me, Elizabeth, all OSIC is trying to do is to get drug companies to create more drugs. And I say, so there's two. Right? There's two, and they don't work very well. And they're 30% of, 30% of progression, slowing it down, but then also horrible side effects. The other thing that I think is interesting, and to Dr. Sequist's point, in my nirvana, it's not just taking the imaging and the biorepository and the sounds, but it's also taking, the clinical notes and using native language processing tools, which are readily available now to try to find patterns in some of these diseases, right? Using bioinformatics, Atul Butte at UCSF, he's one of the best at this in the world, using bioinformatics to find trends, to see things. And then somehow somebody needs to create the magic box that puts all these things together in order to then spit out the therefore. But to Dr. Sequist's point, the frustrating point for us, or me, because I'm from outside the space, is seeing this and trying to figure out how to knock those silos down and bring these together in a meaningful way. But these types of meetings, these types of conversations, I mean, we work on a rare lung disease, idiopathic pulmonary fibrosis and ILD, and fibrosing lung diseases and alpha-1. You're a cancer panel. The way we're going to get there is come together and try to figure out what we can learn from each other. So again, I'm appreciative to be here today.
Yeah. No, this has been great. And so Graham, I'm kind of looking at you, and I must admit that I feel a little bit of an us versus them in the world of the COPDologist, if you will. How do we up our game? For the next 5 years, we're I think we're reasonably intelligent people. We're dedicating our careers to doing this, and it feels like we're still not keeping up. And do we try to blend in more biology to our image analytics, or do we do we still have to crack the case of the subtyping? You know, is it that an insurmountable a task? How do we get ahead of these guys?
In the COPD world, I was going to put on my primary care hat and say I have nothing to do with COPD. But yeah, no, I mean, I do think there's significant progress. You know, it's a relatively you know, like lung cancer, and it's sort of a smoking related problem, and that was your own fault, and we really have to get beyond that. And I think we're starting to get there. The subtyping, I think, from not just from imaging, but from biological science is making significant advances, as we've seen in the last you know, year or so, and understanding and clarifying disease. So I think, I hope we're on the cusp of really significant movements, but it's obviously going to take better subtyping, better therapeutics, and investment. I was going to say at the end, after listening to some of this fantastic work, you know, to put the more you know, being cautious hat on. You know, we have huge shortcuts we can take from data science and AI and so on and so forth. I think we also have to be careful about what we're putting in and making sure that we are having end up with robust results. And we've just come through the example of, you know, according to some high profile papers, smoking was very good for protecting you from COVID and poor COVID outcomes, which was just a sort of a classic EMR based selection bias that was very clearly shown, an old epidemiologic program and a problem. And so, you know, we just need to be careful about what we're putting in and what we're getting out. Thanks.
I would like to make a comment, break a little bit away from the research, the fascinating research that you all are doing, and these amazing the amazing future that we have ahead. But one of the missions of this panel, of both panels of this session, is and this is an ambition that Dr. Molshine has had for many years, and he's been pushing us to get to this point. Are we ready to start recommending radiologists or pulmonologists or whoever to start thinking about lung health in general, not, you know, when they read CTs, and not only, you know, mention the ILA and then, okay, that goes to the ILA specialist, or mention COPD emphysema, that goes to the COPD, if at all, or just is lost to in the text, and that's all. Are we ready to start developing a narrative to primary care, to other colleagues about, okay, this patient has certain abnormalities on the chest CT that increase the risk of lung cancer, that you know, is a warning about the immunological responses to triggers, whatever. Are we at that point, or are we still going to be writing a white paper about what research needs to be done? And Jim, feel free to complete that question if you want. This is, I know, your ambition.
Javier, no, I think you hit it on the nail on the head. You know, the issue about eating an elephant successfully is by doing it a spoonful at a time. And so we really wanted to find a couple of the first spoons. And to me, having some ability to do what Bill Dahut was talking about in terms of starting to capture a fraction of this stream of screening that's going to go on in pragmatic trials, and look at, you know, simple issues. I mean, if we start having a lot of these CT scans, just from an observational perspective, be fascinating to see what are the correlates of, as we get a much larger group of people stopping smoking, and we can look at those CT scans year after year as they're 55, 60, and whatever. I mean, there's some information there that we never could get at before. When we start talking about dietary or exercise interventions, exercise has a profound effect in cardiovascular disease. And it's totally unstudied in this kind of a population for early lung disease and for early lung cancer. Can we look at that systematically, the immunological correlates and whatnot, and start trying to understand how we may see something in cardiovascular disease and that comes across to these other diseases, or it doesn't. And I don't know, there's just very simple things that could be done that are not going to be real expensive, that are not going to be real intrusive, that could be done to start capturing the imagination of these larger stakeholder groups that are currently quite unengaged.
Dr. Walsh, I think you had your hand up, so I don't know if you had a comment about this.
Well, I put up my hand when we were talking about something slightly different. So the conversation has moved forward a little bit. What I did want, well, there are a couple of things I would say. The first is that in our space in fibrotic lung disease, it is absolutely clear that radiologists only have access to a certain amount. They're only able to process a certain amount of data on imaging, that there's a lot more within our imaging that we cannot, that is visually inaccessible and therefore amenable to probing with computer-based imaging analysis and sort of looking for novel biomarkers. However, there is a tendency, and this particularly applies to the ILA problem, which requires lots and lots of data. There is a sort of tendency that people feel that imaging is the sort of is going to be the ultimate solution to ILA characterization, and pretty much knows us that so far, and there is a limited amount of ILA research, and I think this also applies to established fibrosing lung disease, that imaging gets you so far, but to really sharpen that tool, you need to have other metrics that you can combine with the information you pull from the imaging, usually probably in the form of a proteomic biomarker or genomic classifiers that you combine with the imaging to sharpen your disease characterization. I say this because there was a discussion about COPD and working out subtypes, and it seemed like the conversation was focused on working out subtypes based on emphysema different types of emphysema on CT. And in it, certainly in imaging, there's a lot to be done from, or in fibrotic lung disease, there's a lot to be got from the imaging alone, but it will only get us so far. And I'm an imager, and I'm a thoracic radiologist and a computer scientist, so I have natural biases towards, imaging being super important, which it is, but it is going to be a multi-omic approach to, for example, ILA characterization, probably characterization of progressive fibrosing lung disease. And I suspect that paradigm it can be applied across all of lung disease, frankly. So that was what I was going to say.
But I do think the eating the elephant comment was perfect, because we have to start somewhere, right? One bite at a time. And so this is where you start. And then that's why the clinical data that's coming from the physicians is so important, because some of it has more value on the algorithmic side than others. So I think it's biting the elephant. Let's start with the imaging piece, because we know we have it, to Simon's point, analyzing the metadata that comes with all of that, and then figuring out where we need to go.
Yeah, no, and maybe in follow-up to that, biologic data is fantastic, but clinical data, obviously it's a field of many flowers, but it's still incredibly powerful. That I know there are only 2 therapies for pulmonary fibrosis, but there's a highly varied response to therapeutic intervention. And so, Simon, are you also conditioning some of your analytics on versus off therapy, or a factorial of will this be a responder? Because obviously we normally wait and say, okay, let's measure in 6 months, and did the fibrotic score increase, or what did it do, or thing like that. But are you actually then, is your vision to bring in and say, what are we doing, and how does that generate a patient-specific trajectory for this disease?
Well, yeah. I mean, ultimately, what you want to be able to do is tailor your management plan and treatment according to the biomarkers, including imaging biomarkers that you have in front of you. There's no doubt that we can use CT to monitor disease response or lack of response or degrees of response. When it comes to applying machine learning techniques to this, developing novel predictive models will depend on having the right kind of data sets where you have patients who have been treated, you have a well-defined labeling strategy for your data. So, you know, you're focusing in on one specific treatment perhaps, and getting that data set together. At the Brompton, we have a large fibrotic lung disease data set, and within OSIC, we have a even much larger fibrotic lung disease data set, which includes treatment. But this is something, I'm always amazed when I listen to people talk about lung cancer and COPD, particularly when it comes to imaging. You guys are so far ahead of us in terms of research, it's not even funny. When I give lectures in general respiratory meetings where there are lung cancer specialists in the audience, and we're talking about imaging biomarkers and sort of just starting to scratch the surface on proteomic and genomic classifiers, the lung cancer community, which I am, it's not an area that I'm very familiar with, but they're amazed at how behind we are in terms of characterizing disease. I mean, you guys can characterize different types of lung cancer, and you have classifiers which map directly to treatment plans. We don't have any of that yet. We're not even close to that yet. So when we talk about when we talk about this sort of the goal that we're looking for, we're still looking for markers in the imaging that are reliable predictors of disease progression, before we even get onto the issue of who will respond to this treatment or not. So, I mean, this is why OSIC was founded. I was one of the co-founders of it. This is one of the missions of OSIC, and it's why OSIC is so great, because all of this it comes down to having the right kind of data to power the machine learning research. And that's what, I mean, that is what OSIC is going to facilitate. But I think it's worth pointing out, embarrassingly, that we are well behind, you know, our lung cancer and COPD, certainly the lung cancer community, in terms of our predictive tools.
Well, one thing in our defense, there is at least an order of magnitude difference in the temporal nature of the disease, right? One is an ice cube on a frying pan versus sort of erosion of a mountain, and I think I know where we fall. So
thank you, George. I feel a little better right now.
I had to do something. I didn't want to go into lunch thinking like we're done. But,
yeah, oh God, what are we doing? Right.
No, but I do think having a panel like this and really understanding the power of the multi-scale analytics is hugely important, right? And just recognizing the efforts that people are taking and to build these data sets and unifying them. I see we're getting near the end of the session. Javier, is there anything else before we turn it back over to Al that you want to call out?
No, I just wanted to add a comment to what Simon just said, and I'll speak as a pulmonologist, and I do feel that we're way behind. I mean, COPD, we know, for instance, and Graham showed us, you know, the pig puffer and the blue blur. We've been talking about this for decades, and for centuries, actually. And we still talk about that. And we know about emphysema. There are emphysema patients that do not have obstruction, but they do have abnormal physiology. And now Gold has decided to call them pre-COPD. They don't have obstruction, so they're pre-COPD. Whereas I'm seeing these people in my clinic all day, and for me, they're different patients. Are they different diseases? They're different, probably immune inflammatory reactions to triggers, but they behave completely different. So I think we have to become more sophisticated. And I think oncology in that sense really beats us by a lot. Go ahead, Simon.
Yeah, I just want to make sure that everybody's clear that I'm not the sort of harbinger of doom when it comes to where we are. Actually, quite the opposite. It's a reality check, and this should spur us on. I mean, when we see our colleagues in the lung cancer community and where they are, this should spur us on. And the fact that there's quite a lot of low-hanging fruit for us to pick makes our field incredibly exciting right now. And you know, with the data sets that we're pulling together, there's a whole expanse of, to be Shakespearean, the undiscovered country before us. So this is stuff that should inspire us, not that. I mean, I accept what George just said, but I get excited by this rather than feeling disillusioned or demoralized.
Perfect. Graham?
Yeah, just to follow on that, because I just wanted to clarify that the slide I showed represented about 10 years of unsupervised machine learning work on 3,000 CT scans, and ultimately found the most common phenotype was almost word for word blue bloater. And one could react that psi, we've known about this forever, there's nothing new here, and how depressing. That was not my reaction. We now have a very precise phenotype that applies to hundreds, thousands, tens of thousands of patients, actually probably more than that across the country. We already did a GWAS on this. The top hit was close to the dopamine receptor 1, which sits next to and is expressed on the pulmonary epithelium, where it's involved in MUC5AC hypersecretion, which we previously published in the New England Journal as being important in chronic bronchitis. It's associated with bronchitis, and that gene also is involved with exaggerated hypoxic pulmonary vasoconstriction, and we found big right ventricles in these folks too. So this is, I think, really exciting. It's just one example and from one group of what we're able to do that I think has the potential to massively move the field forward. And the fact that the guys in the Lancet in 1966 were right is only, you know, I think makes it better. So anyway, I just wanted to kind of not sigh and say, take a deep breath and we should go for it. Thank you.
Yeah, no, that's a great wrap up. So really, thank you, everyone. Awesome discussion. And Al, maybe let's kick it back over to you to do a wrap up.
Sure. Yeah, I want to thank everybody as well. The discussion, the interaction, couldn't have hoped for a better workshop, couple panels. I know some of you, 2 hours, really appreciated it. We do have a breakout session to further talk about clinical situations later today at 4:30 Eastern for those of you who are available. We have a couple other guests invited to that. But in the meantime, we're going to break for lunch. And then at 2:15, I'll come back to the next session, which is really about the bright future of image acquisition, calibration, and artificial intelligence. So again, thank you very much. This is a workshop, so I may be in touch with some of you again to talk about next steps. I hope I didn't twist your arms too much to be on these panels, but thank you.
Thank you.
Great. Thank you, everyone.